Hey, very good afternoon, folks. Welcome to this unique panel discussion. The reason why I call this panel discussion is unique is because the topic around democratizing healthcare data isn't something that's discussed very often and in many forums very openly, right? And what we're going to be doing is to precisely start analyzing that particular topic in a way that we get different perspectives from different kinds of personas of people and across different geographies. Uh, and to aid that, we have a very eclectic mix of the panelists here today. For a very quick introduction, Viren Shetty is a leading and a very distinguished healthcare provider in the country. Next, we are joined by Jayashree Kalpathy, who is a very eminent associate professor from the Harvard Medical School, focusing primarily around machine learning and informatics. And interestingly, she builds learning models as well. So, very, very apt for this discussion. And lastly, we are joined by Vidur Mahajan, our very own person who's actually leading the flag, of healthcare data analytics in the country, right? So thank you very much for being here, right? So with that, the way we'll structure this panel is I'll probably open it up with a quick question, which will be open to all of us to kind of, as an opening remark, and then move around between us on the different questions. So, you know, if I look back and I start setting the context of this discussion, AI and digital tech is becoming more and more pervasive in the entire journey of healthcare, especially focusing around research, collaboration to drive either cost efficiencies or better clinical outcomes, right? And as this gets more and more pervasive, everybody's beginning to realize that data is holding a lot of key towards how we analyze it and what we get out of it, thereby almost setting the base for what the next few decades would look like, right? With that also then comes the fact that people have started looking at data as something which is extremely valuable and start looking at holding on to it or start thinking, what can I do with it? So, with that as the context, I would really like to first, open this up with getting a quick 2-minute response in terms of what your views are around how is data critical in the decades to come in healthcare. And with that, Jayashree, I'll start off with you.
It's really important and really good question. One thing that we know as we build these AI models that can be so helpful is that the models are only good as the data that they have access to. So to build a model that is robust and will work in different populations, you really need to have access to data that comes from these diversity of populations, whether it is ethnicities or age or even things like BMI. So many things need to be considered when we are thinking about how best to build a model that might work across populations, whether it's globally, nationally, locally, whatever. I think the main key thing is having access to lots of very diverse data. So that's a really important question.
Viren?
Thanks, Neil. Without looking at what goes on in the wider world, just the data generated by my own organization and the hospital that we have across the country, you cannot imagine a modern manager or a doctor being able to function without granular detail about what's going on in every single department at every single minute of the day, right? So just to give an example, if you're the head of supply chain, you have to plan your stocking and purchasing based entirely around what the usage patterns look like. And that involves reading huge amounts of data and building an algorithm that's able to predict that. If you're an ER physician and you're planning the staffing, you're going to want to know whether 2 o'clock on a Thursday in January is very different from, let's say, midnight in the middle of the week in a completely different month. And so usage patterns, the clinical information, spending information just informs every single aspect of what we do, because otherwise hospitals tend to be very reactive, in which case we're responding to the situation in front of us. And what that means is we tend to be overstaffed, we tend to overcompensate, possibly stock too many medications, too many instruments, too much slack that's built into the system that allows you to prepare for anything that could happen, which is fine For a first world environment where there's a lot of money in the system and healthcare is generally something people don't compromise, but in a country like India where everyone is paying out of pocket and margins are really low, this slack is very expensive for healthcare institutions. And if we want to make healthcare affordable to 1 billion Indians, we have to do everything we can to understand how to run hospitals a lot more efficiently. And doing that without very good data understood well is impossible.
Great, Vidar. Thanks. Vidar?
So thanks, Neil. Yeah, I think Viren's put it beautifully, right? On the administrative side of things, on the clinical delivery side of things, not having access to real-time data is no longer an option, right? You are nothing without that, essentially. What I'd also like to point out is this whole side of clinical automation as well. We know that there are not enough doctors globally to cater to the population that we have. It takes 12 years of high school and 12 years of school, and then 6 years of medical school, and then 3 to 4 years of residency, and then 3 more years of super specialization, and then you start your career, right? So it takes 2 decades for somebody to become a doctor. So even if we start making more doctors today, it's an exercise in almost in futility given the way the world is growing. So that's when this beautiful technology of deep learning kind of emerges and says that okay, we can take extremely narrow tasks that are currently done by humans, by doctors, and automate them using whatever AI. But the challenge is that all of this AI deep learning relies heavily on the availability and ingestion of massive amounts of data, right? For example, if we take and Jayashree's worked on this extensively, the case of diagnosing breast cancer on mammograms, right? So every woman on the planet who's above the age of 40 needs to get a mammogram done. And there are clearly less number of machines than there are women. But still there are machines, even in our country, that go empty, right? We'll do 5 mammos a day, 7 mammos a day, 10 mammos a day. Why is that the case? Because you need this really smart person, a radiologist, to look at each of those mammograms and then, essentially describe whether or not there is cancer in that mammogram and thereby in that woman or not. Now, there are deep learning algorithms available today that can look at those mammograms and say what the probability of a cancer is or is not in that specific mammogram. So these tools can be deployed in our clinical workforces today, and these can enable radiologists to go from reporting 10 scans a day to 100 scans a day, right? Because they act as assistants, they act as autonomous. We like at Carpal, we are working on autonomous AI systems where we combine multiple AI algorithms from commercial vendors and try to do all that stuff. So, but all of this is dependent on finding the training data, the data on which the AI models are created. And then, as Jesse mentioned, we need data of different ethnicities, different geographies, different equipments, different gender, different body structures, all sorts of things, and then this universal kind of model is created. So in order to accentuate the capabilities of doctors, the starting point is to find enough data to be able to create those models.
So it's interesting whether you said that the starting point is to find enough data, and Jashi, my next question to you is really that word enough tries to accentuate that entire problem statement, right? Which means that there's nothing like enough if you really need to get to a very, very smart model at the end of the day that you're building, right? In your view, are the healthcare providers and the custodians of the data becoming more and more open towards collaboration, pooling the data together so that it eventually helps mankind and eventually starts, figuring out different models around it, right? How do you see that?
That's definitely a thorny subject for many people. I think a lot of people see data as having so much value that it's not useful to share it from their perspective. On the other hand, there's definitely a lot more interest in sharing data, because I think everybody recognizes that for both their own good as well as a more common good, having these models have access to lots of data is really important. So even for a model to be deployed locally, if a model was built using many different data sets, it's more likely to work well for their own situation compared to something that is built on a very narrow data sets. But there's a point even beyond willingness. Even if people are willing to share the data, the technology and the logistics and the challenges around that are not trivial. There's a whole question of anonymization that I'm sure will come up later. There are ethical concerns. There's logistics, just physically moving, or as we get better at imaging, for instance, we get better resolution, the image sizes go up. The studies get more complex. We now have 2D, 3D, 4D data sets, and these data sets get so big that the sheer logistics of shipping around data gets complicated. Many countries have very strict laws about sending data outside the country. So we have to be careful about that as well. So, and things like GDPR and HIPAA in the US, UK and the US, or Europe and other countries, makes it so there's lots of technical and ethical and other regulatory concerns that make this a challenging question. The US, for the federally funded research, is going to have a mandate for how federally funded data should be made more publicly available. So starting in 2023, at least a lot more of the research data might get public. And there have been efforts for a number of decades in the US with things like the Cancer Imaging Archive and ADNI and other things where, again, from a research perspective, people have been willing to share data. Some institutions like Stanford and others, RSNA, have also worked a lot at making multi-institutional data sets public. And for those of us who work on the more technical end of things, this has been great. But many institutions are very, very risk averse. So the privacy and the cost to de-identify data makes it prohibitive to share data.
Hey, thanks, Jayashree, for that perspective. Now, I know the challenges that you mentioned. These are very, very pertinent ones, and I think some of it, at least Vidur and me have been racking our brains around as to how how do we frame problem statements around those so that we get targeted responses. Vidur, I'll come back to you very quickly now. And so, if we were to address the challenges, in a very collaborative way in the ecosystem, right? And in some form, if I were to kind of take a canvas and paint that there were in the best situation, a world where people are coming together. I know it's not easy, but even if you were to say that, let's start somewhere, right, and get a network of people coming together to at least scratch this at the tip of the iceberg, right, and then it starts creating a momentum and a life of its own, right? Who do you see are the constituents of such a alliance or a collaborative effort, right, and why?
That's a super insightful question, Neil. I think there are two obvious constituents, right? One is the healthcare providers themselves, who are, as you put it, the custodians of the data. They're the ones who own the infrastructure on which the data is both generated and stored, right? And this can be hospitals, this can be imaging companies, this can be the government, various entities, anybody who's delivering healthcare. And then on the other side are the users of this data, right? It could be AI companies, it could be researchers, it could be pharmaceutical companies, anybody who is wanting access to this data for building products, for conducting research, for figuring out, for running regulatory trials, whatever the case might be. But there's also, intermediaries in this whole ecosystem, right? And there's also the most important constituent, which is the patient, right? Which nobody really thinks about very often, but they are essentially the most important ones there, right? But there are consenting mechanisms available. There are, you can essentially take the patient out of the equation using anonymization, right? Which is, never being able to figure out whose scan it was. Right, that's the current legally available methodology for a lot of this stuff. But then there are also companies and service providers that allow this cleaning and transfer of data, right? So, and there's two ways it happens. The first is where the healthcare provider will use a software, a platform, similar to what we are building at Couple, will use that to essentially first mine through the data, then retrieve it, then anonymize it, ensure that it's absolutely clean, and then transfer it over to the other side for analytics, right? And that's how it generally happens. Like all data from these different hospitals gets pooled into one central repository. But now, there is this amazing technology of federated learning that's available, right? Where you don't necessarily need the data to leave each hospital. It can reside wherever it is. Not only hospital, it can reside in its continent, right? The European data stays in Europe, US data stays in US, Indian data stays in India, and you can still have this AI researcher slash developer access not the data, but access a machine learning model that is trained across these multiple sites without having to, ever physically look at or touch the data. And that's the power of these newer technologies, right? And Intel leads the world in this stuff. But yeah, this is just an outlay of everybody. Of course, there's the hardware companies, there's the cloud companies, there's everybody who pitches in to enable this transition. But broadly, this is how the ecosystem is laid out.
Because actually you mentioned all these companies there. Interestingly, there is also, and it's interesting you spoke about the consent mechanism as well, and then the whole anonymization piece in it, which is today, goes back to a very tough point about the quality of the data that exists, right? And to try and say, okay, I'm going to anonymize a data which may by itself not be at a great quality, right? It's a very, very tough call, right? Especially for the healthcare providers, right? There, but you rightly mentioned there are ecosystem players who are gearing up to take over that space, right? And say we will bring in that service at the end of the day because it's an opportunity, right? I'll put an Intel plug there. You mentioned federated learning. There's an additional nuance to it, which is called the secure federated learning, which actually protects the folks like Jayashree who build models so that their models themselves don't get compromised and the models go towards the data. But that's an Intel plug there. Wherein my question to you there is, we heard Vidur talking about the various constituents, and in that, one of the most important constituents is the custodians of the data and the healthcare providers, right? How do you see the healthcare providers and the hospitals open to such a network and participating in such a network? And also, I know personally for you, as you and me have spoken before, right, there is a lot of challenge around the data quality, right? And how this would take off in the initial days, it's not going to be an easy task. It's going to be very uphill, right? But that doesn't deter some of the forward-looking folks who say, hey, we have to face that problem someday or the other, right? So how do you see that? Do you see at least some hospitals coming forth and leading the way and paving the way as some things start getting resolved out?
So if you were to ask me, what would it take for hospitals to be part of this, of a large federated learning environment where they're sharing the patient data, and all of you all have mentioned that. And it would be the same motivation that anyone has. And when you ask, why am I getting up every morning? It's money. The opportunity to make it now, either by selling patient records or the opportunity to make something useful in the future that could either cut cost, that could improve throughput, that could generate a new treatment protocol, that could make money somehow. I think that underpins all the talk around the data security, my patient, my information, so much work, all of that. Or even if, let me break it down even simpler than that. There's that silly saying, right? Data is a new oil. And it sounds very elegant, and people say, wow, yes, oil is valuable, therefore data must be valuable. But think about it for more than a second. Let's say you dig in your backyard, your kid starts digging with a spade, and they find a huge Permian basin worth of oil over there. And you're a regular homeowner who works in an office somewhere. That oil is useless to you. You need to process it. You need to put a giant rig to drill it up. You need a refinery to turn it into something useful. The kind of organization that you'd have to create to make your data useful doesn't exist in nearly any hospital, barring the largest university health systems. And even then, even after all of that, the value that could be extracted from one patient's longitudinal level data, it's extremely hard to quantify, and I'd be shocked if it's more than a couple of dollars a person. There was an Indian startup that came to me and said that we have this app, we've got a large number of people using it, and we have longitudinal history of all of them. We've digitized all their records, and you can take a chronic patient going back 20 years, and we'll give you a really nice dashboard which has all of that. It's a great, And they said, how much would you pay for each person's thing? And I thought about it for a minute, and I said, I don't know, maybe 5 rupees, 10 rupees at most. And the guy's face just fell, because he was under the assumption that it's worth thousands of rupees per patient. But then I would say, you're giving me stuff that's nice to have. It's not going to change my life in any way, because I could ask the patient the same thing and be able to record that. And that's just part of the normal patient interaction process. So anyway, so for hospitals to want to collaborate on this, there'll be very clear and possibly even selfishly motivated reasons for them to do so. If you want to use a fancier word for that, you can call it aligned incentives. Right? What is the incentive for the hospital to be a part of it? Because here's a fact: the data is not clean. It requires a huge amount of work. It is siloed, even in a large organization. I won't speak for ourselves, but there are many organizations that have, let's say, multiple EMR systems running around. They store imaging data across multiple formats. They store all the past patient history in PDFs or JPEGs. And the patient records even don't match, and there's no single unified patient ID. It's not easy to put that all together. Now, you can absolutely put that effort, put it all together. I don't know what it will cost per patient, but if at the end of the day, if it costs you an X amount of money to put it together, if what you can do with that and earn from it is not a multiple of X, no hospital is going to want to put that together in the first place. And that's the problem. There's a huge amount of work that will be involved in making it clean, but those problems are not data problems. Those are IT, tech, software problems that most hospitals are still in the process of figuring out.
Jashi, I'll just take the cue from what Virendra said. How do you put the value to the data with so many other problems associated with this, right? And the challenges associated. This is such a tough question, right? I mean, this has a recurring value, but the recurring value is so long term that people sometimes, it doesn't just make sense. So while it is needed today to happen, right? How do you really put a value to the data with so many, kind of metrics around it?
It really is a really tough question, as you said. I mean, there's many different ways to think about it. There's sheer quantity, but that does not necessarily translate to value, right? So you can just take the data dump with no curation of any sort, and it'll be completely useless. The more you refine it, I mean, the refinery is potentially an interesting way to think about it, right? The more you have the crude oil, but as you go up the refinement stack, the value might go up. So if you have just raw data, it's not as valuable. If you curate it and have things like annotations. So for radiology, for instance, just having the image may not be as useful or just saying image plus this condition may not be as useful as having a localization. So bounding box or a segmentation or some kind of very precise spatial localization might be helpful. The longitudinal aspect was considered is important. Even things like the patient context, right? Looking at just a lung of somebody without knowing how old they are, whether they've had radiation, something else like that, you lose a lot of the context that defines the data. And so just making imaging data or just making some data available without context can be hard.
Hey, thanks, Jashi, on that. At least from what you and Viren just mentioned, it's very, very clear that data is being monetized today. And like Viren also said it, right? Why would somebody do it because of what we get up in the morning for? So I think, in many ways that actually puts that ethical question a little behind us, and people are more forward looking around it to figure out, hey, there are different ways to look at this and a different lens to look at this. Whether you speak to so many different hospitals as a service provider, right? Primarily around, how do you kind of do the data transformation for the hospitals, right? I'm sure have you been approached by multiple hospitals in the country today for monetizing their data, right? And if so, what are the kind of challenges you face when you actually take them through that journey, either from a privacy perspective or from just generally being able to convince them to come over on an innovative platform and stuff like that? How do what's your experience been there?
Honestly, Neil, monetization, uh, the word itself, trivializes the effort that goes into creating
That's true.
something that is actually monetizable, right? So when we speak to both AI companies, hospitals, we actually don't say data monetization, we say domain monetization, right? Because the data, so like Jeffrey said, a chest X-ray or a chest CT scan alone is nothing, but a chest CT scan that is reviewed by 3 radiologists who are subspecialists in chest medicine, and they've made not boxes, they've made polygons around each of the lesions on each of the slices of those X-rays, and you know that this patient was exposed to 3 different types of chemotherapy over the last 3 years, and this is like been the journey of that entire patient, and you looked at each image, make sure there's no name of the patient. If it's a head CT scan, you cut off the nose of the patient so that you can't even reconstruct the scan and figure out that who it was. Once all of that is done, right, that's when you start hitting the several $100 kind of category. But that's not because the patient was who he or she was. It's because you've had these experts spend significant time and effort. You've had software that was built by again experts, that has processed all of this data, and then emerges this data set of sorts that can then be given to somebody like Jeshri to go ahead and create a very great model that can predict on day one of a CT scan what the outcome of that patient would be from a 5-year time period, right? So that's I know I went off on a bit of a tangent, but that's what it actually takes to create a data, the crude oil into I don't know what the most pristine, like the 99% rocket fuel kind of thing that actually sells for the most out there. But there is obviously. There's effort, and wherever there's effort, there is resistance, and wherever there's resistance, there's the impression that the world is not interested in it. But as people start seeing outcomes, as right now, the most common use cases are breast cancer, lung cancer, stroke in the head, tuberculosis of the chest. Yeah, all of these are hardly 5, 7, 10%
Yep.
of everything that happens in a hospital, right? But the moment things starts hitting 30, 40, 50% is when workflows will start changing, right? I use this analogy of pathology, right? Where if you have a pathologist signing out, 500 reports a day without blinking an eyelid, and because they have quality management systems at the back, making sure that they only see the 50 patients that matter, that's when radiology and, other clinical sciences are going to start becoming truly automated. But I think it's just a journey we all have to go through together.
So, Vidur, I'll come back. So, I think you gave a very good perspective there. So, finally, Viren, being the custodian of the data, being a very premium healthcare institution, right, who leads the way in many ways, what would be your vision on something like this, right? When people really start opening up to collaborate on the data front, how would you lay the vision, not only in the domain, but also, in this country, which is actually trying to catch up in the digital health tech space by leaps and frogs, actually jumping over generations right now?
We've been fortunate. We started in a time when there was a great demand for healthcare services. As an organization, we've been able to scale. And we have the resources to be able to support a very large data science team. Now, that is not available to most hospitals. A 50-bed nursing home in a small town would not be able to get a data science team. And what we're planning to do with our team is that there's 2 kinds of data. There are those that are these moonshot projects, and that involves a lot of the stuff that gets written up and papers get published on. So right now, there's a lot of COVID-related data. There's a lot of imaging data that we're analyzing. And there's interesting therapies, the interesting insights that can come out of that. And there's one small segment of the team that would work on that. And these are the things that get published in scientific journals. And if an algorithm comes out that's useful, great. We want to make it available to the whole world. And that's something people can use. But the more prosaic, day-to-day, practical application of data, and this is something I believe that every hospital should eventually get into the business of cleaning, managing, owning their data, because you don't need to run very complex algorithms to decode CT scans. You could just have an Excel file and someone analyzing the in and out times of patients every day, right? Which is the time the patient checked in, the time they saw the doctor, the time they came to the billing count, and the time they left. Right? You build a culture of data in an institution. Pretty soon, that becomes the basis with which you start to demand better information. You start demanding the managers of your hospital to get better, EMRs, to get better software technology that you can run your hospital better. You can see patients faster. You can waste less time. You can make more money. That is what I would leave the organization with. Like, this is not science fiction. Maybe the science fictiony parts are science fiction, which is clinical decision support systems, AI that can treat patients manually. Yeah, all of that. Maybe it's a little beyond the reach, but there's very basic and simple things that people can do. Like the most basic algorithm to just tell you how much time to allocate for a person. You just need to run an average on the total number of in and out times that you get, and that will give you information. And even that is data science in its crudest way. And so that's something that should absolutely be democratized, and everyone should start playing a more active role in this and thinking that, yes, I mean, the data is valuable, the information is valuable, and there are insights that you could share with the whole world.
Hey, thank you, Viren. I think on that note, we just run up on time. So thank you so much. Once again, I think a great discussion. This is not going to be the last of its kind. And I'm sure we all will look forward to collaborating in some shape, some form, evolving this journey out. Thank you.